it should be an annual colonoscopy until they have that intervention. But there are a group who we don't have the genetic diagnosis, and so they actually have to have a diagnostic colonoscopy. So it's important that we realise that. The at-risk relatives, we start off with flexible sigmoidoscopies, 13 to 17, we do it annually. At age 18, a full colonoscopy, and then they have a colonoscopy every 5 years and a sigmoidoscopy in the intervening years. Clearly, if you establish a diagnosis on a flexible sigmoidoscopy, it is then annual colonoscopy. So this is a video clip, which is usually very well because they never work. But we'll give it a go, if I can get the pointer.
So if you go back.
You go back on the one. So this is a clip courtesy of Brian Saunders, just really to highlight about how we should be doing diagnosis. And one thing I've beautifully put out, which is being raised commonly, is the role of chromendoscopy. So this is a diagnostic colonoscopy. I think most people say there's probably a lesion there on that fold. And this is then the appearances, and you'll see it run through when chromendoscopy has been performed. Now lots of people say, well, it's just getting close to the mucosa, it's just that you're taking more time, but I truly believe that in FAP it's hugely important. So there's data from Marina Wallace at St Mark's. They reviewed all their attenuated patients over a 5-year period. People referred in with attenuated polyposis, all of them with dye spray colonoscopy. Their diagnosis was changed to classical FAP. There's also data from Japan with Matsumoto's group, which has shown that both NBI alone is superior to white light, but chromendoscopy is significantly improved over and above NBI. So you can see here lots of these really pretty small, subtle lesions, and undoubtedly it can transform the way we manage these patients. So the next stage, operative planning. I've said that the vast majority of these patients will go through to surgery, and really the choices there are colectomy and denial-rectal anastomosis, or a restorative panproctocolectomy. A panproctocolectomy and endoilostomy pretty much is no longer performed unless it's for low rectal cancers. So there's always debate, and I've got some old surgical colleagues in the audience who might question this, but to me there is no right or wrong operation in FAP. It should be individualised according to the patient. And there's good data to show that there's some areas that you can look at to actually predict the right operation. So from Sue Clark's group at St Mark's, they've looked at factors and age and the underlying genetic mutation